If blood pressure medication is part of your daily routine, there are five specific things that quietly push your readings back up. And at least one of them is something you have almost certainly done this week without a second thought. Most people on these medications never hear about any of them, not because their doctor doesn't know, but because a 7-minute appointment leaves almost no room for this conversation to happen. Blood pressure medication, whether you're taking an ACE inhibitor, a calcium channel blocker, a beta blocker, or a combination, works by either relaxing the walls of your blood vessels, slowing the force of your heartbeat, or both. But its mechanism interacts with specific foods, habits, timings, and over the counter decisions in ways that are predictable, documented, and almost never discussed at the point of prescription. A review published in the Journal of Clinical Hypertension found that a significant proportion of uncontrolled blood pressure in patients on medication was not caused by the medication failing. It was caused by one or more of five specific modifiable factors that could have been identified in a single conversation. My name is Dr. Qalb. Before we continue, do not stop, reduce, or change your blood pressure medication based on this video without speaking to your prescribing doctor first. Everything I describe here is information to raise at your next appointment, not a decision to make on your own. I want to tell you about a patient named Margaret. She was 71, a retired librarian, methodical by nature, and had been managing hypertension for 9 years without a single crisis. Over a period of about 3 weeks, several things happened that seemed entirely unrelated to her at the time. We will come back to Margaret throughout this video, because by the time she came to see me, four of the five things I am about to describe had all occurred within that same short window, and together they had pushed her systolic reading above 190. She had no idea why. Those five things were a glass of grapefruit juice, a new packet of ibuprofen from the pharmacy, a week of disrupted sleep, a heavily salted ready meal she had during a difficult patch, and a decision to take her tablet at a different time of day so she would not forget it. None of these five things on their own sound dramatic. None of them would make anyone pause. That ordinariness is exactly why they matter, because nothing about any of them triggers the sense of caution that a person would naturally apply to something that felt dangerous. Thing 1: grapefruit and its less obvious cousins. This one surprises almost everyone, and the mechanism is worth understanding properly. Your liver contains an enzyme called CYP3A4. Think of it as a gatekeeper that decides how much of a drug actually gets absorbed into your bloodstream. Most medications are metabolized partly by this enzyme, which keeps your blood levels within a safe and therapeutic range. Grapefruit contains a group of chemicals called furanocoumarins that effectively block this gatekeeper, not for a few minutes, but for up to 72 hours after a single glass. Think of that enzyme like a valve in a water pipe. The valve is designed to let a measured amount through. Grapefruit jams the valve open. Suddenly, the full dose floods through instead of the controlled amount, and your blood pressure medication becomes significantly more potent than intended. For calcium channel blockers in particular, medications like amlodipine, felodipine, or nifedipine, this can cause a sudden and unexpected drop in blood pressure, leading to dizziness, lightheadedness, or fainting. Patients often attribute this to dehydration or standing up too quickly. They rarely connect it to the grapefruit they had at breakfast. If grapefruit is a regular part of your diet, do not simply cut it out without speaking to your pharmacist first. The interaction varies by medication type. Ask specifically, does my medication interact with grapefruit? That is a 30-second question at the pharmacy counter, and you can ask it today. Seville oranges and pomelo carry the same risk, so mention those too. This interaction is one of the most well documented in cardiovascular pharmacology, but what comes next is different. It is not about what you eat, it is about something you buy without a prescription. Stay with me. Thing 2: ibuprofen and other anti inflammatories, the hidden pressure. This is the one that catches people most off guard, partly because ibuprofen feels like a basic painkiller, the sort of thing you take for a headache or a sore knee without giving it a second thought. But non-steroidal anti-inflammatory drugs, NSAIDs, directly interfere with blood pressure control through a specific kidney mechanism. Your kidneys produce substances called prostaglandins that help maintain healthy blood flow within the kidney itself and also encourage your body to excrete excess sodium. NSAIDs block the enzymes that make prostaglandins. When prostaglandin production falls, the kidneys retain more sodium and sodium retains water. More fluid in the circulatory system means more pressure against the vessel walls. Think of your blood vessels like a garden hose. The hose has a fixed internal diameter. If you turn the tap up, more water, more pressure. The pressure at the nozzle rises. NSAIDs effectively turn the tap up by increasing the fluid volume your heart is pumping against. In patients on ACE inhibitors, ARBs, or diuretics, this interaction is particularly significant and can raise systolic blood pressure by 3 to 5 points, sometimes considerably more with regular use. If you have been managing a painful joint, a back, or a shoulder with ibuprofen or naproxen over recent weeks, this may be contributing more to your readings than you realize. Paracetamol taken at the correct dose does not carry this risk for most people. If you need regular pain relief and you are on blood pressure medication, ask your GP specifically about the safest option for you this week, not at your next routine appointment in 3 months. The difference matters. The next thing is something you do every night, or perhaps lately do not do quite as well as you used to, and its effect on blood pressure is more powerful than most people imagine. Stay with me. Thing 3, sleep. And what happens to your cardiovascular system during a bad night? Blood pressure does something specific when you sleep well. In the hours of deep sleep, your blood pressure naturally dips, sometimes by 10 to 20%. This nocturnal dip is not just restful, it is biologically necessary. It gives your cardiovascular system a genuine period of reduced stress, and researchers have found it is associated with significantly lower rates of stroke, heart attack, and organ damage over time. When sleep is disrupted, whether by pain, worry, an uncomfortable environment, or sleep apnea, this dip does not occur. Your sympathetic nervous system, the system responsible for your body's stress response, stays activated. Cortisol and adrenaline remain elevated. Your blood vessels do not get the period of relaxation they are designed to receive overnight. Think of it like a spring that is never allowed to uncoil. Under continuous tension, it eventually loses its ability to return to its resting position at all. Patients who are classified as non-dippers, people whose blood pressure does not fall during sleep, have measurably higher cardiovascular risk than those whose blood pressure does dip, even when their daytime readings are similar. If your readings have been rising gradually over months and your sleep has also been difficult, this connection is worth raising explicitly. A sleep diary, even a simple written note each morning about how you slept, is something you can start today that gives your doctor genuinely useful information. If your partner has ever mentioned that you snore or stop breathing in your sleep, ask your GP about a sleep apnea assessment. That one question could explain a great deal. Tell me in the comments right now, has your doctor ever asked you about your sleep when reviewing your blood pressure? Type sleep if this has never come up in your appointments. If uncontrolled blood pressure is something you or someone close to you is navigating, subscribe now. The next video in this series covers the medication timing question in much more depth, and it changes what a lot of people do every morning. Thing 4, dietary sodium and why the risk is not where most people look. The link between salt and blood pressure is something most people on medication have heard before. But the practical reality is more specific than eat less salt. And that vagueness is part of why it so rarely translates into change. The kidneys regulate blood pressure partly by controlling how much sodium stays in the body. When sodium intake is high, the kidneys retain water to balance the sodium concentration, a mechanism called osmotic pressure regulation. This increases blood volume, and increased blood volume means the heart must work harder to push blood around the body. In patients on certain blood pressure medications, particularly diuretics and ACE inhibitors. Dietary sodium can directly blunt the medication's effect. Think of a diuretic like a drain in a bathtub. It is working hard to remove excess fluid. Excessive sodium intake is like leaving the tap running at the same time. The drain cannot keep up. The practical challenge is that most dietary sodium does not come from the salt you add at the table. It comes from bread, processed meats, tin foods, ready meals, condiments, and restaurant food. Sources where the sodium content is invisible unless you read the label. A single ready meal can contain more than 2 grams of sodium, close to the full recommended daily intake in one sitting. Look at the labels on three things you eat regularly. Not to change everything overnight, but to locate where most of your sodium is actually coming from. That knowledge is specific and actionable. Bring those numbers to your next appointment. Thing 5: Medication timing and the missed dose mistake. Blood pressure medication is designed to maintain a consistent level of a drug in your bloodstream over a 24-hour period. That consistency is the point. When you miss a dose and then take two the following day to compensate, or when you shift the timing of your tablet by several hours because it fits better into a changed routine, you create peaks and troughs in your drug levels that your cardiovascular system was never designed to manage. Some medications, particularly beta blockers, carry an additional risk. Stopping them abruptly, even for a day or two, can cause a rebound effect where your blood pressure rises above where it was before you started taking the medication. This is not failure, it is pharmacology. But it is dangerous and it is avoidable. Think of the drug level in your bloodstream like a reservoir that feeds a steady stream. The medication refills that reservoir once a day. If you drain it faster than you refill it, or refill it inconsistently, the stream runs dry in the middle of the night, and your blood pressure rises during exactly the hours when your doctor is not measuring it. Set a daily alarm for the same time every day with no exceptions. Link it to an existing habit, your morning tea, your evening meal, something that happens regardless of what else is happening that day. If you have missed more than one dose in recent weeks, do not guess at how to catch up. Call your pharmacy. They will tell you exactly what to do, and the call takes 5 minutes. Margaret's systolic reading when she came to see me was 193 over 104. She had been drinking a small glass of grapefruit juice each morning for 3 weeks, a habit she had started after reading it was good for vitamin C. She had also been taking ibuprofen daily for a painful knee. Her sleep had been broken for most of that period because of pain and worry, and she had shifted her tablet from morning to evening because she had been going out more and kept forgetting it. 4 out of 5, together in 3 weeks. Her reading normalized over 10 days once we addressed each factor in sequence, and at her follow up appointment, we sat down with her medication list, her diet diary, and her sleep notes. She told me, I knew about blood pressure for 9 years, and I still didn't know any of this. Margaret's story is a grapefruit juice and an ibuprofen packet, and a few difficult nights and a tablet taken at the wrong time. None of those things is dramatic. That is the point. Blood pressure medication works by maintaining a carefully balanced relationship between the drug and the body's systems over time. The 5 things in this video are the 5 ways that ongoing relationship gets disrupted without anyone noticing until the disruption becomes a number on a monitor that frightens someone. One final detail: if you are having a surgical or dental procedure, ask specifically how your blood pressure medication should be managed on the morning of the procedure. Some anesthetic agents interact with antihypertensives and can cause significant blood pressure drops during surgery. Others require the medication to be taken as normal. This is a 2-minute conversation with your surgical team or GP beforehand that prevents a problem on the operating table. Ask before the appointment letter arrives, not on the morning itself. Which of these 5 things was new to you? Tell me in the comments. I read every single response personally. Share this with someone who has been managing high readings despite being on medication, or with someone who has recently been prescribed antihypertensives for the first time. These are the conversations that do not happen in the appointment, and they should. In the next video I'm publishing, I'm covering beta blockers specifically, including one timing detail that is the mirror image of the medication timing issue described in this video. You will want to see that if a beta blocker is part of your daily routine. Most people watch this video and forget this channel exists by tomorrow morning. If this matters to you, 1 second is all it takes. This is Dr. Qalb, 5 ordinary things, 1 medication. Now you know all 5. I will see you in the next.